Today, I'd like to cover a brief basic informational session on cavernous malformations of the brain. And in this presentation, we're going to cover what is a cavernous malformation, what can cause cavernous malformations to develop, what symptoms a cavernous malformation can cause in the subset of patients that are having symptoms. We'll also talk about how cavernous malformations are diagnosed and what the treatment options are for these cavernous malformations. And following this short presentation, I'll answer some frequently asked questions that we see in our clinical practice with patients with cavernous malformations. And for the purposes of this talk, if the term cavernous malformations will be abbreviated as CM, standing for cavernous malformations. First of all, a little bit of nomenclature. Cavernous malformations of the brain are called by several different names, and I wanted to kind of just explain what these names are. So when you see these names in the medical literature, essentially these are all one and the same. I use the term cavernous malformations, and I think this is the most common term used. You'll also see the term cavernous hemangiomas or cavernous angiomas, which again are just one and the same with cavernous malformations. And then finally, this is perhaps a little bit older term, AOVM, which stands for angiographically occult vascular malformations, of which cavernous malformations are a subtype. What many vascular malformations do is they show up on an angiogram, which is a dye study looking at blood vessels. But cavernous malformations don't do that. And so they are occult, which is silent or not visible on angiograms, hence the term angiographically occult vascular malformations. So what is a cavernous malformation? They are essentially a cluster of blood vessels located in the brain. And unlike blood vessels that have a function of carrying oxygen to the brain tissue, cavernous malformations are a cluster of venous blood vessels in the brain that really are effectively a shunt. They don't serve a purpose of providing blood to the brain. They're just basically a shunt from arteries to veins, but they are essentially on the venous side. So they are low pressure. They're not high arterial pressure, but they're low venous type of pressure malformations. Again, they do not supply blood to any normal brain tissue. And because they are veins, they're not really under high pressure. Like other blood vessel abnormalities of the brain, cavernous malformations can hemorrhage and bleed. And their bleeding pattern is different than it would be for a high pressure arteriovenous malformation. Cavernous malformations just tend to ooze and puddle blood around themselves because the blood is under low pressure. And if you had a cavernous malformation in the palm of your hand, it would look similar to a blackberry. It would have little bumps on itself. So here's a kind of a magnified picture of what a cavernous malformation would look like. You can essentially see a cluster of grape-like bumps. Each of these circles is filled with blood products that are under low pressure. So we know that cavernous malformations can occur in any part of the brain, and they can be very, very tiny, essentially a millimeter in size, barely visible on imaging studies, to several centimeters. You can have a 2-inch cavernous malformation, for example. A lot of patients that have these cavernous malformations live their whole life without knowing that they've had one because either their symptoms are not significant enough to warrant any workup or intervention, or they just never have a event where the cavernous malformation has any significant bleeding that leads to their discovery. So the actual prevalence of cavernous malformations may be much higher than we know. Some patients can have multiple cavernous malformations, and those typically are patients that have genetic versions of cavernous malformation. We now know there are a number of genes that lead to the development of cavernous malformations, and we'll talk a little bit about that in a subsequent slide. The advent of MRI scans in the mid-1990s has led to the cavernous malformations being found more frequently. Prior to that, CT scans were developed in the early 1970s. They could detect the larger cavernous malformations, but not the tiny ones. And before you had CT and MRI imaging, these cavernous malformations were almost impossible to detect. Occasionally, you might suspect them if there was a hemorrhage in the brain. But again, brain hemorrhages are usually diagnosed with CT and MRI scans. So prior to the advent of those studies, cavernous malformations were typically only found on autopsy studies. There are several different mechanisms by which cavernous malformations are thought to form, and I want to discuss the three most common types that we see in our clinical practice. The first is what we would call a solitary or single or sporadic cavernous malformation. And this is the most common type that we see. It's in a patient that has one cavernous malformation and nothing else. There's no family history of cavernous malformations. There's no multiple cavernous malformations. It's just a single cavernous malformation. And in these patients, it's thought to be a congenital lesion, meaning the patient could have been born with the cavernous malformation, and it resided in the brain quietly for years to decades before being discovered. Another version of cavernous malformations are the so-called genetic versions that I mentioned. In this situation, patients have multiple cavernous malformations in their brain, and multiple may mean hundreds potentially. They often have a family history of cavernous malformations, and our genetic counselors now know how to test patients with multiple cavernous malformations to see if they carry the genetic version of this. This has consequences in terms of testing other family members and in terms of impact on the patient if they were to have children of their own. And finally, there is a type of cavernous malformation that is radiation induced. And what this means is a patient who has had prior radiation to the brain for some other reason, like a tumor, for example, can develop cavernous malformations in the area of the brain that was radiated. And this typically occurs between 5 and 20 years after the radiation treatment. And so a radiation-induced cavernous malformation can look like perhaps recurrence of a tumor that was previously treated, but in these cases, it's not a tumor, it's just a development of a cavernous malformation. So what symptoms do cavernous malformations cause? As we talked about, a large number of cavernous malformations are completely asymptomatic. These are quiet structures in the brain, often very small, and don't really cause symptoms. So a lot of people are walking around with cavernous malformations in their brain, and they don't necessarily know about it. If the cavernous malformation starts causing symptoms, it usually means that there was a prior hemorrhage or bleed from the cavernous malformation. And recall that the bleeds from these cavernous malformations are not high pressure arterial type of bleeding. They're very low pressure puddling of blood products around the cavernous malformation, creating essentially like tree rings around the cavernous malformation. And we can see this evidence of prior bleeding on MRI scans even years later, because the iron pigment in the human blood that carries the oxygen to the tissue stains the brain with this iron pigment and leaves essentially like a shadow that I'll show you on some images. It essentially will leave a shadow around the cavernous malformation. But if you do have symptoms from the cavernous malformation, the three main categories that we see symptoms occurring would be headaches, And as you can imagine, those can be challenging to diagnose because we all get regular tension headaches and stress headaches, but you can get headaches related to cavernous malformation. And usually they're more frequent, more constant. They localize to the area of the brain where the cavernous malformation is located. A kind of a chronic headache evaluation often involves obtaining an MRI scan. Seizures are typically common in about a third to a half of patients with cavernous malformations. And that is because the blood products from the prior bleeds of the cavernous malformations are often very irritating to the brain tissue, and this irritation causes seizures. In some cases, the seizures can just be managed with medications, but in other situations, surgical resection of the cavernous malformation is the ideal way to eliminate the seizures. And the third category is what we call progressive neurologic deficits. And what this means is the patient will develop a neurologic deficit that will gradually worsen over time as the cavernous malformation repeatedly hemorrhages or enlarges because of repeated bleeding. And so a patient may develop some numbness or tingling in their leg or weakness in their arm, and that symptom may progress over time to become more consistent or more severe. They may develop some speech difficulties. If the cavernous malformation is located in the language area of the brain, they may develop some visual deficits if the cavernous malformation is located along the visual pathways. So progressive neurologic deficits is the third category, and about 1/3 of patients with cavernous malformations fall into that set of symptoms. This is a picture of a cavernous malformation that we see on this scan here. There's some evidence of bleeding, and this is more in kind of the acute phase. Now, how are cavernous malformations diagnosed? We talked about prior to CT and MRIs, they were nearly impossible to see. But now with these scans, we can pick them up pretty easily. On CT scans, cavernous malformations appear as a circle, different density than brain tissue. Sometimes if they've been there for a while, they can have some calcium in it, like bone, areas of the cavernous malformation that have fossilized. And sometimes they can also show acute blood products if you happen to get the CT scan at the time of the bleed. Now, in this picture here, the CT scans are the two pictures in the middle, and it's a little bit hard to see on the scans because, again, the quality of CT imaging is not as good as MRI, but cavernous malformations can appear as a circular difference in density on these scans. If you look over to the right, this is what an MRI scan looks like typically, and the cavernous malformation is much easier to see. It has a very black ring around it that we'll talk about in a bit in terms of what that means. So on MRI scans, as we've seen, cavernous malformations are more clearly defined than CTs. On MRI scans, there's certain radiographic terminology that physicians use when describing cavernous malformations. Sometimes we say they have a popcorn appearance, meaning specks of black and white colors alternating within the cavernous malformation, representing different ages of blood products or perhaps some areas of calcium within the cavernous malformation. On certain MRI sequences, cavernous malformations can have a black ring around them, and that's a very classic defining pattern for cavernous malformation. So this is a coronal view of the brain, and looking at the brain stem, we see a cavernous malformation. This measures about 1.5 centimeters, and it's located in the brain stem, so a deep structure of the brain, but it has kind of that black and white speckled appearance that I talked about, that kind of popcorn appearance that makes it pretty classic for a cavernous malformation. This is another cavernous malformation located in the thalamus, again, another deep structure in the brain. And we see the difference in color patterns within the cavernous malformation, the whites and the gray. But you also see this black ring around the cavernous malformation, and that is evidence of prior hemorrhages or bleeds. The black ring comes from the iron pigment in the human blood products. And anytime you have a hemorrhage or bleed, the blood slowly absorbs over time, just like a bruise in your arm would gradually absorb, but it leaves behind in the brain the iron pigment. And that iron pigment is what creates this black ring, which is a pretty classic appearance for cavernous malformation. So what are the treatment options for cavernous malformations? The key to remember here is treatment options are highly individualized for each patient, and they're largely based upon the size of the cavernous malformation, the location, what symptoms the patient is having, how frequently they're having the symptoms, and also the age of the patient. And so it's very important for a detailed evaluation and workup to be performed to obtain the best outcomes for management of cavernous malformations. And this would entail reviewing MRI scans of the patient and having a discussion of the symptoms, a discussion of the expectation and resolution of the symptoms, and a discussion of the risks of removing the cavernous malformation. So, this sounds like it's overly complex, but it's actually not. Oftentimes, it's just a review of the MRI scan, and at a center like ours, we see a lot of these cavernous malformations, and we frequently do review MRI scans of patients outside of Stanford to render second opinions regarding treatment options. So let's talk about the different options. The first option is what's called observation. And essentially, this is just monitoring the patient. So we're not recommending any surgery or any intervention for the cavernous malformation. This is often recommended if the cavernous malformation is found as a incidental finding. So, for example, if you have an MRI scan because you were in a car accident and the cavernous malformation was discovered and you didn't know anything about it and it wasn't bothering you and wasn't causing any symptoms, and particularly if it's small, we would just say, let's just keep an eye on it. And what this means is ordering periodic MRI scans to look for any changes in the cavernous malformation. What we're looking for is patterns of repeated hemorrhage or bleeding that may make us think that the cavernous malformation is more active than quiet. Observation is often a treatment choice for elderly patients. If the patient has lived their entire life without any problems from the cavernous malformation, it may not make a lot of sense or be necessary to surgically intervene to resect them. And in some areas of the brain, which would be considered high risk, it may be better to observe the patient unless the cavernous malformation has declared itself as active with multiple hemorrhages, because a lot of these high risk areas of the brain have elevated risk of morbidity if you perform surgery in those areas. Surgical resection is the mainstay of treatment in those cavernous malformations that are treated, and we often recommend it in the following circumstances. The first would be if the cavernous malformation is symptomatic. If you're having debilitating headaches impacting your quality of life, if you are having seizures that are not controlled well with seizure medication, if you're having a progressive neurologic deficit that's continuing to get worse and worse, we would consider surgically resecting the cavernous malformation to achieve relief. Sometimes we recommend resecting a cavernous malformation if we have radiographic evidence of frequent hemorrhages in the brain. And in this situation, we would say, just by nature of the hemorrhages and by the risk that each subsequent hemorrhage may cause a permanent neurologic problem, we may want to be ahead of the curve here and resect the cavernous malformation. Many cavernous malformations are in low-risk areas of the brain and can be easily removed with a short operation and a short hospitalization. Occasionally, surgery may be recommended even in the higher risk areas of the brain if the cavernous malformation is particularly active. So here's an example of a cavernous malformation that we see. It's about 2 centimeters in diameter. It's got evidence of some hemorrhage around it. This is something it's large enough, and in this case, it's been growing on set of MRI scans dating back several years. So the fact that it's getting bigger and the fact that it has repeated hemorrhages has shown that the cavernous malformation is worthwhile to consider to remove. So a question that often comes up is, we know that for other types of vascular malformations, such as the high flow vascular malformations made of arteries, we know that radiation has been used to successfully treat these blood vessel abnormalities for many decades. So the question is, does radiation work for these low flow, low pressure cavernous malformations if it works for the high pressure vascular malformations? And both our group at Stanford, as well as groups at Harvard and Pittsburgh in the 1990s, studied this situation. And all three groups showed essentially that this was not the case. Radiation doesn't typically work for cavernous malformations. It doesn't obliterate the blood vessels. And in patients that had cavernous malformations that were resected after radiation treatment, what we found when we looked at the resected cavernous malformations is the radiation did not obliterate any of the blood vessel channels through the cavernous malformation. So, in the 21st century now, we don't use radiation for cavernous malformations in terms of treatment. This is going back to the image that we showed before. This is a treatment plan that we did in the 1990s when we were trying to plan radiation for these cavernous malformations. This is a cavernous malformation in the brain stem, so it was considered a high risk area of the brain to operate. And so we planned a treatment course of radiation to the cavernous malformation. And as mentioned, the results of this series of patients, we had about 75 patients that had radiation, is that radiation didn't seem to really obliterate or eliminate the cavernous malformation. So that was a basic presentation on what are cavernous malformations and how we diagnose them and what symptoms that are present. At this point, I'd like to go over some of the frequently asked questions that we typically see in clinic, and hopefully by answering them, it will also answer some of the questions that the audience may have.
Then, if I have a CM bleed, will I necessarily have symptoms?
So the first question is, we talk about these cavernous malformations, bleeding, and how will I know if I have a bleed? Will it automatically be correlated to symptoms? So the trick here is, I think we have to divide the patient population into two groups: those that know they have a cavernous malformation and those that don't even know they have this. So the majority of patients that don't know they have a cavernous malformation, if they did have a bleed and they got a mild headache, they might just chalk it up as a tension headache. Now, obviously, if the bleed was more severe and they developed weakness or numbness or speech or visual changes, they'd be in the emergency room getting evaluated. But many of these cavernous malformation bleeds can be very small and subtle, and therefore not create any symptoms that the patient would be concerned about. However, in the second group of patients, those that know they have a cavernous malformation, I think they're much more attuned to what to expect based on the location of their cavernous malformation. Their physicians have often told them what symptoms to look out for. And so if they've had a small bleed in a cavernous malformation in an area of the brain that's, let's say, located next to the vision cortex, they will be more in tune to be looking out for subtle visual changes that may be associated with the bleed. And in that situation, they may be more likely to know that they've had a hemorrhage that particular day.
If I have symptoms from a CM bleed, what could those be?
So the question is, if you have symptoms from the bleed of the cavernous malformation, what could those be? And that the common list I like to use is headache, seizures, and progressive neurologic deficits with 1/3 of each, all of the patients assigned to each category. So if you have a bleed, about 1/3 of the patients will present with headaches. If you have a bleed, about 1/3 will present with seizures. And if you have a bleed, about 1/3 will present with progressive neurologic deficits. So a seizure or a significant neurologic deficit will prompt a workup that will lead to a cavernous malformation. Headaches or kind of just feeling a little weak or tired may not be specific enough to prompt a workup. But generally with cavernous malformations, if they are active enough to the point that they either repeatedly hemorrhage or repeatedly cause symptoms, eventually they will likely be discovered.
If I have a documented bleed from a CM, what is the chance that I would have a second hemorrhage?
So that's a good question. There's been some research looking at bleed rates from a cavernous malformation. And I think what we typically like to use is what's called a annual hemorrhage risk. So what is the percent chance that in a given year that I will have a bleed from a cavernous malformation? What we also know is that what we call the superficial cavernous malformations, or the ones not located in the deep areas of the brain, they have a lower bleed risk than the cavernous malformations that are located deep in the brain. So by deep, let's think of the structures in the center of the brainstem, the thalamus, basal ganglia. And the hemorrhage rate for cavernous malformations that are superficial is thought to be about 2 to 3% per year chance of having a first hemorrhage. And the chance of a deeper brainstem hemorrhage is somewhere between 6 to 10% per year. So you can see how a deep cavernous malformation will have a higher hemorrhage rate, 3 to 4 times higher per year than a superficial cavernous malformation located in the shallow areas of the brain. Now, once a cavernous malformation has a hemorrhage, it is more likely to hemorrhage a second time. For example, we talk about the shallow cavernous malformations having a 3 to 4% per year hemorrhage rate. A second bleed could be as high as 15 to 30% chance on subsequent years. And if you're dealing with a deeper brainstem cavernous malformation, it may be 30 to 50% chance of bleeding in the next few years. It does appear that cavernous malformations often cluster hemorrhage, meaning that if you have one bleed, you're likely to have a second bleed in the next couple of years, but then it quiets back down. It's a little like some follow-up tremors after an earthquake. So after one earthquake, you're likely to have some smaller follow-up tremors, but once things settle down, then the bleed pattern may settle back down to a much lower rate. But again, 3% for the superficial AVMs, and about 8% annual hemorrhage rate for the deep AVMs, both of which increase once you've had the first bleed.
Take a blood thinner medicine for another medical disorder that I have, will that increase my risk of a hemorrhage?
That's a great question, because there's a lot of disorders such as heart disease or stroke prevention, or clotting disorders, in which patients take blood thinners for valid reasons. And the question always arises, well, now that I'm on a blood thinner, will that either A, increase my chance of a cavernous malformation bleeding, and B, if I do have a bleed, will the bleed be a larger bleed than it would have been if I wasn't on the medication? And I think at this point, this is a big gray zone. You have to have a frank discussion with your doctor about the pros and cons of this, because oftentimes the anticoagulation or the blood thinners is done to prevent a pretty significant problem from occurring, like a stroke. And in this point, you're doing a calculated risk assessment here. You need to be on the blood thinners to prevent a stroke, but if you are on a blood thinner, will that change the cavernous malformation hemorrhage? In general, my basic philosophy here is if a patient has not had a bleed documented on MRI scans for a number of years on their cavernous malformations, and if they're on blood thinners for a significant valid medical reason, I usually err on the side of letting them go on the blood thinners. But again, this has to be a discussion because each patient is individualized. Obviously, a patient that just had a hemorrhage a week ago from their cavernous malformation, we would have a lot of concerns with them being on blood thinners. So you really need to individualize this for each patient.
At high risk for cavernous malformation hemorrhage if I am pregnant.
So there's a couple of situations where this could happen. The first is you have a patient who during their pregnancy somehow gets an MRI scan that determine that they have a cavernous malformation, or the more likely scenario is you're following a patient conservatively with MRI scans for asymptomatic cavernous malformation, and now the patient becomes pregnant. We know during pregnancy there's changes in blood volumes and fluid volumes in the pregnant individual. And that led to some people to believe that there was a higher risk of hemorrhage during pregnancy. The best data that we have right now does show that there is not a difference in hemorrhage risk during pregnancy. And so in those patients that do have a cavernous malformation, if they're pregnant, we usually, unless the cavernous malformation is frequently bleeding, we usually let the patient carry the pregnancy to term, deliver the child, and then address the cavernous malformation after the child is born.
Now that I'm diagnosed with a cavernous malformation, what can I do to prevent a bleed from my cavernous malformation?
Right, that's a great question, probably almost the number one question we see in clinic. It's really not known what causes cavernous malformations to bleed. They can hemorrhage when you're sitting on the couch watching TV. They can hemorrhage during your sleep. So it's a situation where we may not have a lot of control over the factors that control bleeding, just because the bleeding is so random. However, we do think that there are certain things that we can do to potentially reduce the risk of bleeding. The first is, which is much less common these days, but that's if patients are smoking, they should stop smoking. If patients have uncontrolled blood pressure, they should work with their doctors to get the blood pressure under control. It's thought that kind of de-stressing your life, either with regular exercise, good sleep, meditation, yoga, things like that just really reduce stress, may be beneficial. And then lastly, sort of related to the blood thinner topic, there are a number of supplements that when taken in high doses can thin blood. For example, vitamin E, if you take 50 times the recommended dose, it can thin your blood, for example, and that can be counterproductive. But basically, it's control blood pressure and keep stress down are the main factors.
If I
So,
have multiple,
go ahead.
if I have multiple cavernous malformations or am thought to have a genetic version of cavernous malformation, what are the next steps in the workup?
So this topic comes up when we see patients that have the presumed genetic version of cavernous malformations, and there are really two circumstances where we suspect this. The first is when the patient says, I've had other family members have brain hemorrhages in the past, or have had bleeds in their brain, or have had neurologic deficits from an unknown problem. then we and the patient has a cavernous malformation or two, then we suspect the genetic version. However, most patients that carry the genetic version have multiple cavernous malformations. So when we're looking at the MRI scan, we see many, a dozen, 50, sometimes even hundreds of small cavernous malformations. And in that situation, it's from a clinical standpoint, it's pretty clear they have a genetic disorder that they're carrying. But the formal workup involves getting the genetic counselors involved and formally testing the patient for the gene sequences that correlate to cavernous malformations. And as we've gained a lot of knowledge about these genes over the last 25 years, this testing has become more and more routine. So it's fairly common to test the patient and to test family members and to come up with essentially a hereditary family tree of those patients that have cavernous malformation genes that would predispose them to cavernous malformations and hemorrhages. And those would, that's essentially important to determine which people in the family you should screen, which people in the family should be counseled regarding pregnancy and having additional children, and when those children in particular should be tested.
If I want to have surgery for my cavernous malformation, what are the steps for scheduling that, and how does the whole operative process work?
So if it's been determined that your cavernous malformation would be best treated with surgical resection, the initial steps would be to have a formal evaluation at a center that specializes in cavernous malformations. And this would involve a clinic visit, a preoperative visit, a discussion regarding the surgical approaches to the cavernous malformation. You typically would meet with the anesthesia team and plan on a several-hour surgery and several days in the hospital. On the day of surgery, you would be put to sleep in the operating room. The head would be positioned in such a way that it would allow the optimal surgical approach to the cavernous malformation. An incision would be made in the skin. A small opening would be made in the skull with a temporary removal of a piece of bone that is replaced upon completion of the surgery. And during that period of time where the bone is removed, we would dissect down to the cavernous malformation under a microscope using special instruments to remove the cavernous malformation. Once that's been removed, the bone piece that had been removed to allow access would be put back in place and the skin would be closed. Most patients that undergo this type of surgery don't necessarily even need the ICU, so they can go straight to the recovery room and then to the regular hospital ward. And most patients that undergo this type of surgery are in the hospital just for a few days. So I think that covers the questions that we had. Hopefully you found this presentation useful, and feel free to reach out if you have any additional further questions or would like your films reviewed. Thank you.